My name is Stella Micheni. I am a pharmacist at NYERI PGH, and I am here with two of my colleagues, Dr. Pauline, who is our medical superintendent at the hospital, just recently appointed. I know a couple of other colleagues have joined me online. So I work a lot at the CCC clinic, and I have an abstract on Dolutegravir, which is basically a relatively new molecule or class of ARVs that is being used for treatment of HIV. So, well, from my abstract, it's basically, as you can see from the topic, it's the effect of Dolutegravir on glucose control in non-diabetic patients living with HIV, and on metformin at NYERI County Referral Hospital CCC. Next slide, please. So I would love to acknowledge my co-author in absentia. She's Karanja, she's a clinician at the CCC, and we did this project together, and also to basically based on my colleagues, the pharmacists at the referral hospital. Next, please. So we know with introduction of the INSTIs for treatment of HIV infection in Kenya, we have had recent data, actually very recently, 2020, 2021, with the reported cases of weight gain, insulin resistance, diabetes, and in some cases hyperglycemia. And as we are aware, with introduction of new molecules, it comes with several other things that are discovered during post-market surveillance. And part of or some of these things were not really reported before the drug came into the market. So, for example, for DTG is about 4 years in the country since it was rolled out for use across the country. And between 2017 and now, we have seen many things, many changes, and many effects, basically for our patients. So in some cases, we have DKA, but from the few studies I looked at, we did not have cases of DKA reported yet. Next slide. So the study was basically to determine the effect of DTG on glucose control in non-diabetic patients who were on metformin and at the clinic. It's basically looking at our patients who have type 2 diabetes, and also patients who are on metformin. So I excluded patients who are perhaps just being treated with insulin, because that was not part of the study. So as for the methods, we did the study retrospectively in 15 non-diabetic patients who are on metformin. And during the period of optimization, those are the patients that were optimized to DTG, or they were moved to DTG when it came into the country. So for patients who did not have diabetes, but reported cases of hyperglycemia after taking DTG, those ones were not part of this study, but we had also a couple of those patients. So of course we looked at data on glucose control, and we were getting this data from the patient's files and from the electronic medical records softwares or HMIS that are being used at the CCC. Next slide. So from our study and from the files, the Kenya EMR, the IQ Care, out of our diabetic patients, actually the number was 15. So 73% of our patients who are non-diabetics and who are optimized to DTG developed persistent hyperglycemia within 2 to 6 months of being on DTG. despite having been put on the maximum dose of metformin. So we monitored them for about 3 months, of course, with the other interventions before we even think the thought of changing the drug. But when the glucose was not completely under control, we actually switched them to efavirenz, which was their prior. And surprisingly, once we switched them to efavirenz within 2 months, 100% of the patients that had persistent hyperglycemia achieved glucose control. Then we had 27% of the patients who did not develop any hyperglycemia, and after optimization, so those ones were retained on their regimen, but they are on strict follow-up. We are still following them really closely. Unfortunately, for our study, we had a reported case of DKA from these patients. The patient was hospitalized, but after the switch, obviously the patient is now stable and doing well on treatment. Next slide. So really, there's an effect on DTG and on our diabetic patients, and it is really important that even as pharmacists, we have a role to play, especially pharmacovigilance and really looking out for these patients in our workplaces. And obviously, this is a new drug. So among the things that we recommended that we are actually doing at our facility is ensuring that for all patients who are being optimized or rather being started on ART, and they are having the INSTI as part of their regimen, we are doing baseline glucose tests before optimization and also before you start them on ARVs. Number 2, we also need to do routine monitoring for all our patients who we have put on DTG, especially for their sugars, whether they are diabetic or not. And also for people who are diabetic and living with HIV and they have poor glucose control, it is important that when you look at, or when you do all interventions and they are not working, you should perhaps consider switching them back to their prior regimen. And finally, we also need to consider, what is it called? It's integration of our CCCs with our MOPCs and DOPCs. Because again, in some facilities, especially in public, the clinics are completely different. MOPC is run separately from DOPC on different days, and the same patient is seen at a different CCC clinic, which is at a completely different place. So as part of perhaps what we need to be considered is integration of the 3 clinics, and especially for patients with comorbidities, and specifically for our diabetic patients with this worry of hyperglycemia and the complications that can come around it. And I think that's the end of my